Hello everyone, good afternoon. My name is Bashir Mukhtar. I'm a mental health specialist, a graduate of Jimma University, Southwest Ethiopia. And I have worked for 2 years in Ethiopia after I have studied my master's in psychiatry. And then for the last 3 years and a half, I've been working in Somaliland as a director of mental hospitals. And I'm very interested in working with community, and we do have community awareness raising programs, outreach programs, and also we do have collaboration with local community voluntary organizations working in mental health. And also this is also part of our international collaboration, and I appreciate Dr. Sebastian and the good work and the team all. Thank you.
Yes, good afternoon, ladies and gentlemen. I'm Dr. Hafsa Lukwata. I work with the Ministry of Health in Uganda. I'm a public health specialist, but I've worked for the mental health program for the last 10 years. First as just a member there, but in the last 2 years, I've been heading the program following the demise of my boss. And well, I'm very happy that I've gotten this opportunity to come and learn. Been told it's sharing, yes, but I'm sure I'll be able to learn quite a number of things. Community programs are not very well developed. We're mainly dealing with the clinical aspect of things, but I think it's high time that we put this on board as well. So I've got lots of lessons to learn from this and see how to start off the community or strengthen, because I'm sure there's some little disjointed things that are there, but we hope to have it very well streamlined and become perfect in the system as well. Thank you very much.
Thank you. So my name is Ojotunde Masifagusen. I'm a consultant psychiatrist from Nigeria. So I've had like about 10 years experience in mental health services, and I've had an experience from both sides of the world, like community mental health services in a big mental health institution, about the biggest in the country. And then in the last 2 years, I've had to switch role from a specialist mental health setting to delivering mental health services in a general hospital setting. So I'm presently the head of department of University of Abuja, the head of department of mental health, University of Abuja Teaching Hospital. And where basically what is done before I got there is more of consultation liaison psychiatry. And so because of my interest in community psychiatry services, I have my master's in global mental health at King's College London and the London School of Hygiene and Tropical Medicine. So in the last 5 months, I've had to see how I can break the existing barriers. So we started implementing community mental health services in primary health care level. So, and I hope I can say much more about that later and then learn from you people too.
Thank you. Thank you so much. Okay, so just to keep you alert that we may have more people coming in, I'm going to ask that we expand the circle to include them in the discussion. So my next task here is I will take about 3 minutes to set the background on why this is important, why is it connected, and then I also feel that at some point, I mean, need some guidance on this, how best to connect it. I'm looking at you, Doc, because you do this regularly and more efficient at this than I do. But let's use our collaborative effort to share knowledge. So once I lay out the history, the background, and the connection to the global exchange, I feel a need that should we take time for agencies to say a little bit more about what they do and how this is connected, or just go straight into the discussion, and that will come out slowly as we expand the dialogue.
I think people should be invited to speak about something that they see as a connection, either between what they're doing and what's being talked about, or the issues here going on between Africa and the work we're doing in the United States.
All right. So all of you have the handout, which we call the Mental Health Action Plan. If you don't, please raise your hand, we'll send it to you. And why is the Mental Health Action Plan important as a background to making the connection? John, can you, Stephanie has some more in the front that we can get. So when we think about mental health delivery, we think of a couple of ideas that come to us. The first idea that happens a lot is the clinical, what we call the clinical models, where somebody gets sick, either from depression, anxiety, something psychotic happens, and the family and the care systems have to be activated. So we'll call that scenario the clinical entry of crisis points. Now, that is, we're familiar with that, with different parts of the, if you have it, you're doing the copies?
Yes.
We have some more. So you just prepare the background, and I will come back to the clinical part. Then prepare the background because the Mental Health Action Plan is really now adopted by the WHO, but it's work that was started by Harvard and a couple of entities around the world in response to what is called the magnitude of the problem, which is trauma, psychological trauma, as a result of war, deliberate war, violence, and destruction. And so Harvard, having been at this from around the late 70s with the Vietnam War and the Southeast Asian wars, they realized that wars happen, wars cause physical, mental, emotional damage, but there was a need to document it scientifically, and then come from science to application. And so they convened the first council of ministers, health ministers in 2004 in Rome, and they committed to reviewing the literature and developing a book, a guide with best practices. And some of this is what has happened with this plan. I'm going to draw a couple of, I will draw your attention to page 6 under sub 3, which is where they look at the science-based mental health services. In this section, what I was reading through it, they laid out what I really look at the roadmap on how to use science, literature, experience to really begin having a conversation and formulate how you intervene. Again, from the angle of responding to mass trauma and violence, which is high trauma. But so they laid out that guideline. So when you see from item number 1 all the way to item number 5, they address all these systems that include being sensitive to using the data to gather information, but focusing on what we now call culturally sensitive care. I see that they are attending to the indigenous communities, indigenous healing practices. Now we are calling all of that culturally sensitive care as the years have come. But I think this was the beginning of realizing why that was so crucial. In sub 4, we realize under children and adolescents, every society values its young. And we know very, unfortunately, so well here in Milwaukee, that the combination of poverty, urban violence, deprivation have combined to create terrible circumstance, which is impacting the educational outcomes of our children. And so I'm so glad to have Charlie here and Dr. Stanley as part of our partners in care as we work with the schools, because I see that this conversation, while it is very important for the adults, it's even more critical when we move to the children. And I would even go as low as infants. When you look at infant mental health, given what we know now about scientific studies on the brain. So let me also draw your attention to the recommendations in this document on, again, page 7, item 3.1, where there is a focus on really developing best practices. So psychotherapy is an art, but it's also science. And so the focus on using best practices here compels us to be more deliberate and thoughtful. So there's a level of professionalism that we have to utilize. In sub 2, 3.2, there is a focus there again, where they say this should begin with a scientific training of practitioners within the existing indigenous healing system. So the local practices are hereby acknowledged. Just 1 minute. So you see that they are appealing to primary care practitioners. So there is a history way back in the late 1970s, beginning with the Atlas doctrine, Atlas, and then for the literature, where the whole concept of embedding mental health within primary care is conceptualized. Declaration. That was about 1979, 78. So this is the precursor of realizing that mental health issues have to be addressed at the basic levels of healthcare delivery. And so now, fast forwarding to the modern conceptualization, when we talk about integrated care, well, integrated care is now being implemented some 40 years later, when the concept was that it should be part of primary care. And so traditional healers, so here, this is again going back to cultural awareness and wisdom. Family members, school counselors. So school counselors here would also include social workers, principals, administrators, teachers, school aides, all folks, members in the school setting that have to be aware of the school, of the issues that impact community. And then the local and international NGOs. Again, emphasizing that this cannot be done by government alone, can't be done by one entity, but has to be a multi-focal effort to bring back to encourage this work to be done. So that sets for me the background on the mental health action plan and the rationale that has brought us this far. Now, fast forwarding, why this is important for us here at the clinic. It's important because I've been fortunate to be serving this community for now over 30 years, dedicated to it, and been blessed to have people like agencies like yours, individuals that have become personal friends in what I call the trenches of work that we do. So we have to work together. And so as you do that, you also build relationships so that as providers, we have to know each other, we support each other, and share knowledge. So our work in Milwaukee also extends to work in East Africa. I've been fortunate with Dr. Erlinger visiting us now for 3 years in a row to work in Uganda and East Africa now on promoting mental health and recovery care. And that's how I was fortunate to work with the Minister of Health in Uganda, that Dr. Hafsa now is the chair. We worked with her predecessor, Dr. Sheila Ndenabanji, God rest her soul, a woman that worked tirelessly to promote mental health for Uganda and at the international level. Through those conferences, I got to know about Dr. Bashir from Somaliland and Ethiopia, and I'm so glad to have you here. And through the connections we have with West Africa, now we have Dr. Tunde is here. Look at all these young people. It makes me so pleased that as I'm getting old and useless, we have young people that are coming up to really take on the work and carry the baton. From here, they will go to Madison, as I mentioned to you, join the team there, spend another 10 to 12 days dealing with the School of Medicine, the Global Health Institute, the School of Nursing in Madison, the School of African Affairs, make further connections. Tomorrow they will be at UWM, working with Dr. Alinga and the School of Nursing and the MSc program. They'll be at Rogers Behavioral Health to get to know the private sector as how to the nexus between private and public health. And by your being here and having this conversation to me extends that dialogue. So thank you very much, please. So that is the background that I wanted to share with you. And I'm going to open it up to the floor. Tim, help me to make sure we are carrying the conversation flowing well. So what time do we have now? About 20 after? 25 after. Let's, can you each use about 7 minutes, talk about your program, what you do, and what you hope to get from this exchange. And then each five. Charlie, could you be our timekeeper?
Sure.
You can
Look
at when the good finger goes up. Okay, so who wants to go first?
Oh,
Saturday.
okay. Thank you once again. So, like I earlier said, that have been basically involved in two models of care, considering mental health services delivery in a resource-constrained setting like Nigeria. So a kind of quick background, Nigeria is about 200 million people. As of the last check, is going to that by the recent national census data available. And then we have just about 200 psychiatrists. So that takes it down to like an average of one psychiatrist to 1 million people. And then probably clinical psychologists, social workers, other mental health service provider, maybe they're a bit more, according to recent data from the Mental Health Atlas 2017, which is a WHO document. So what we see basically in the country is that the service delivery is skewed in that most of the people that need mental health services are in the rural area, but the primary healthcare system is really not working. So there's next to nothing about mental health care services and primary health care. So the center where I worked, where I did my postgraduate training, is one of the foremost psychiatry institutions in the country. We call it Neuropsychiatry Hospital, Arabelkuta. So, and we have like 7 of them in the country, which are like regional and psychiatry hospitals, because my country is divided into 6 geopolitical zones. So the government tried to put a psychiatry hospital in each of these geopolitical zones. And then we have teaching hospitals that have psychiatry department, but the psychiatry hospital are standalone. So, and they're developed in the model of the colonial settings. So both where I was, by 2010, they started a mental health and primary health care model. So, and that was scaled up to all the local government. There are 20 local government there. So, and it kind of bring a new face to the thing. But so there was creation of clear referral pathway. So these are run in clusters, and then there are psychiatric nurses that are supervisors of those facilities, and then there are psychiatric consultants that are in charge of those clusters. So if in very severe cases that they need to consult them, they make visit to those places like once or twice in a month as needs arise. There's drug revolving fund, essential medication list, where the nurses are the one that take the medication from the hospital to them, and then there are primary healthcare workers who have been trained and are supervised by the nurses. And so there is clear existing pathway of referral, and that has gone on for like 10 years. But the problem is that there are pockets of this in the country. It's not well coordinated. So it's based on institution innovation. It's not something that is coming from the federal government. Even though the MH gap we're talking about, which is what the WHO has recommended for the delivery of mental health services in resource-constrained setting and a non-specialized setting, which is based on the concept of task shifting, so that middle and low-level grade health workers can actually deliver some of these services. So it's kind of pretty working well in that setting, but the problem is the scaling up. And so I left that place when I came back from the UK, moved to Abuja, and then I found myself in a different setting. So there is the Department of Mental Health there, which is almost not really functioning. They were admitting before, but the issue of stigma, there was isolated cases of violence, and then so the institutional barrier came in, the nurses, even doctors, and saying that, no, we're not going to admit her again. So when I got there in 2017, that was what I met on ground, and then trying to change the narrative. And it's so paradoxical that I can't get my patient admitted, but if they come in through consultation liaison, the same patient they can keep in the ward for 2-3 weeks. So, but just thinking outside the box, I decided to say we are starting community mental health services. So we had collaboration with WHO. We got primary health care workers to get trained in the hemorrhage gap, some of the modules, and that's what we've done. Presently, we do community advocacy, and then we are just at the implementation level. We are expecting funding from the local government to just pilot this for 1 year. And then after that, we'll scale it up to other local government areas. Thank you.
Okay, thank you. Set the clock. Sorry about that. Okay, again, I'm Hafsa from Uganda, and I'm heading the program, the Mental Health and Control of Substance Abuse program at the Ministry of Health. And the situation I'm in is that we're at policy level. I'm not in service delivery, but our role as a ministry is to supervise service delivery. But before we supervise, we set the standards, we put the laws, the policies, the guidelines in place, and it's against that background that we go down to ensure that those standards are being implemented as said. That said, I would like to inform you that Uganda has participated in a number of researches and discussions at regional and international level that have resulted into policy shifts or even changed direction. And actually, we're very proud about that. We have participated in the MH gap. Dr. Sebastian has talked about the MH gap, and it was mainly set for low-income countries to ensure that we get a package of care for people with mental disorders, but also to help the primary health workers to be able to work, because I would like to tell you it's a similar situation. We have a total of 32 psychiatrists in Uganda, and against a population of 40 million people, over 40 million people. So it's one psychiatrist to more than 1 million people. So that became very difficult for service delivery, of course. So we've had a middle cadre that has been trained. They're trained for 2-3 years, depending whether they've been working before or not. So, and this cadre is called the psychiatric clinical officers. They've done quite a lot. These are quite a number of them. There are so many, and they cover quite a number of the facilities in the country. And these, again, do not cover everyone. They're not, it's not enough. They're not enough. They're about, okay, they're more than 1,000, but they're still, the gap is quite big. So what we decided to do as a country was to train the general health workers. And before the image gap came out, we had a little book. We had a little book that we were training people on, and it had been designed by the psychiatrists. So it was like a mini psychiatry book. So when the image gap came on, it made things much lighter. So it was easy for the general health workers. We managed to train the general health workers into managing mental illnesses generally at primary health care level. So yes, it has reduced the stigma a bit. The health workers are not as fearful as they've always been to care, into getting care, to providing care for the people. And yes, we have piloted it as a country, and still under WHO guidance. And I think we have good lessons to share with the rest of the region and the world. And it is not so, it doesn't require lots of funds to do it, and it doesn't require, it's easy to implement. Everyone can do it, even a midwife. Their maternity units can easily use it to identify mothers who could become potentially depressive or could have some mental health problems. So we pushed it to that level, and well, we are happy with what is happening at that level with our involvement in research and informing policy somehow. So the other thing that I wanted to share with you is the fact that we have just had our revised, it has been passed, our mental health law, the Mental Health Act. It was given to us by the president on Christmas Day. So he gave it as a Christmas present to people with mental illness. That's when he assented to it. And it's in there, we have a lot of issues that have been brought out on human rights and, how to care for people, treatment, the different treatment options and so on. But unfortunately, I think it's infringing on quite a number of other laws in the country, and it's creating a bit of a dilemma. It may require changing quite a number of laws, already existing laws, as it gets implemented. So they're trying to put a little stop to it. Okay, yes. So well, we are having some issues there. So I'm going to do a lot of learning for it from here. We'll do a bit of learning there. So the other thing, 1 minute. Okay, in that just last 1 minute, I'd just like to say that in service delivery, we are mainly doing the clinical aspect. I've already talked about it. We are still very naive. We are still very raw in as far as community mental health is concerned. My boss, as Doctor has told you, also participated. I think they must have attended some similar training. So they were part of this mental health action plan. And in it, there was somewhere where they were telling us to implement community mental health. So she brought it and put it into our documents and said, it's going to be community mental health. How this will happen has never been sorted out. So, and that actually at one time we're told, guys, why don't you remove this, because you don't seem to have any targets, you don't seem to have done anything, because I think it was as early as 2011 or 20, some time early. So we've had a revision, 5-year plan revised, and we didn't have any data, we didn't have anything that we had done to it. So we're told, please drop this and let's work on some things that you're really, that are more visible. And so for me, I'm glad I'm here and I'm listening in for community mental health. I think I'm going to bring it on board. And luckily, our strategic plan is ending 2020, but this is an opportunity for us to start thinking about the next plan. So really, mental health, community mental health is going to get back into our strategic plan. And this time around, I think we are much clearer of what I think we should be able to do. So that's for now. Thanks for listening.
Thank you. I'm Dr. Bashir from Somaliland. Basically, originally, I'm from Ethiopia. I grown up in Ethiopia, born there, and I've educated a degree and master's level in Ethiopia. Then, after I have finished my graduate studies in integrated clinical and community mental health program, a kind of joint program by Jimma University of Ethiopia and Ludwig Maximilian University of Germany. Then I went back to the university sponsoring university in Ethiopia, and I have worked for a year and a half as a lecturer and psychiatric unit leader at Medolab University. Then I have moved to Somaliland, where burden of mental illness is very high comparable to other countries. And for the last 3 years, I'm working as a director of Gebile Mental Hospital, located about 20 miles away from the capital, Hargeisa, capital of Somaliland. And the hospital established and started providing service by 2016. And the hospital has a history of a kind of an interesting history, because the hospital is built by the advocacy of voluntary community organizations. And voluntary local community organizations called Samakal, which stands for supporting good deeds. And Samakal is Somali language, so it stands for supporting good deeds. And the voluntary local organizations established by 2008 started with an interesting idea of contributing a small amount of Somaliland shillings on a daily basis from every individual in the community. Those who are engaged in small business, all voluntary individuals in the community, from 1,000 Somaliland shilling, which stands for 0.1 USD, which is equivalent to 0.1 USD, which is not big, much money to pay for people. So with that idea, by collecting this money for about 5 years, then they have got a potential to influence the governmental stakeholders and government sectors, private limited companies, and private organizations, and also international organizations. Then they have also contributed some percent. And finally, the hospital has built by this history. And still the hospital is run by government, National Ministry of Health Department, and also in collaboration with the community voluntary organization that I have mentioned earlier. And the hospital provides service for a wide range of population, and as we are few in number, similar to what my colleagues have reported, for over 4.5 million people in Somaliland. We are only four psychiatrists in the country. We are very limited in number, but we usually do have discussions, and we meet every month and we discuss. And currently we are updating national mental health policy. the hospital provides for one wide range of population to not only Somaliland, but also people from Djibouti and Ethiopia are getting service from mental hospital where I work. And majority of the cases visiting the hospital are severe mental disorders, psychotic disorders, and emotional disorders, and also trauma-related, stress-related disorders are there. And statistically, looking into the 3 out of every 4 clients visiting our hospital do have severe mental disorders. 1 of every 2 clients do have severe mental disorder, psychotic disorders like schizophrenia. So it seems the picture or epidemiologically, the prevalence of severe mental disorder is high in Somaliland because of trauma and war history in the past. However, Somaliland is very peaceful and have no problem of security recently. We can understand the sequelae of trauma even many years later can have an impact on mental disorder. Yes. Okay. And finally, to conclude, and we provide inpatient and outpatient service, community outreach programs by visiting nearby towns, community awareness. We work with traditional and spiritual healers to deliver community awareness, and training and education. We are engaged in universities teaching medical students psychiatry practical and theoretical courses. And also this is part of collaboration thing here, visiting to you guys here in Milwaukee. This is also part of our collaboration. Thank you very much.
Thank you. Thank you so much. So let me open this up for discussion, sharing. As you do that, you can mention your name and the connection.
So what strikes me is that we feel we have a shortage of
Yeah.
providers.
Exactly.
And we do, actually, not nearly to the extent that you do. We have a lot more providers, and we still have the discussions that you're having, how, particularly for child and adolescent, adults too, but particularly for child and adolescents, we do not have enough psychiatry or people who can prescribe medications at highest level of education for behavioral health. People scramble, people don't know what to do. We have people traveling miles and miles as you do to get care. And we have the same discussions. And actually, I was at a discussion at a conference about a week ago, actually today, talking about doing some of the things that you were doing to have more lesser people with lower educational level, entry level people doing more. And yes, absolutely. Yeah. So we can learn from you. It might be more that way than the other.
Well, if I can speak to that. So this is global mental health. And then we just find out that the problem are the same everywhere, just with different shades. So when we talk about treatment gap, they are everywhere. But maybe in high income country, what statistics have shown is the treatment gap would be like between 35 to 50%. And then when we're talking about low and middle income countries, we're talking about 75 to 90%. So you have in my country, maybe for every 1 person that comes to the hospital, there are probably 8 to 9 people that won't come. And for so many reasons, different reasons, maybe up here, stigma, there's stigma back there too. But talking about finance, availability of alternatives. So you're talking about 200 psychiatrists in Nigeria, but you have thousands of traditional healers, thousands of pastors that are ready to offer it for next to nothing. but in the long run, you find out that it's more costlier. And if you put the aggregated cost implication, so these things that when we talked about stigma, the attribution, what they put it, and then we start this conversation there too, and there's stigma there too.
Oh, yes.
So,
yes.
but the issue of even what we need to learn from each other, but very appropriate too in the global mental health community, what people say is we could learn from each other, but it all still boils down to one thing. Whatever you're learning, you need to contextualize it. It needs to be culturally appropriate. But when we're talking about exchange now, you're talking about the migrant community. So you have people coming from Africa, from Asian country, and then they are part of you here. So it's not going to be a one size fits all. So we have to look at, okay, for the Somali people that are here, for the African community, what is their belief system? And then how? Now they're Africans now here. And so we need to have a tailor-made service provision for them. Why the same concept that they came back from home, that they brought from home, why it affect their health-seeking behavior? They traveled with it down here. So it's not going to change. So it's a carryover. And so all these barriers, the cultural competency of service providers need to be improved on so that they can offer something that is culturally appropriate and at the same time that is individualized care, taking every word as they come. No two patients, no two clients, even with the same diagnosis, are actually the same.
So it's not complicated at all.
I have a question for the group. I've had people talk about refugees, and I'm just wondering whether the people who come into here continue to be referred to as refugees, or they should be having another name. Are they new migrants? Or I'm asking this, and does that bring a bit of stigma to whatever they do and how they are thought about in this when they come into this community? Because being a refugee and being a person who is come and to stay, it's really a difference. So over to you guys. How is that?
I can probably adjust it a little bit. Yeah, we tend, especially because it's politically charged now, and with the new government we have, it is very politically charged. So many times we prefer to say they are immigrants.
Yeah.
But when you're among, I think, at least from my perspective, sometimes when you're among those that are doing service delivery or addressing things, at times you have to address that they're refugees because, again, there are certain perspectives, certain situations that they come with. But in public, at least, I know that we refer to them as immigrants. We, as any other immigrant that is coming in, but they do carry, they have their own unique circumstances that we want to make sure that we're able to serve them. But if I can just ask something related to the question that was asked before, because again, when you're talking, it looks like on average you have one psychiatrist for every million people. This is honestly, it's a very difficult situation. Do you also have a shortage, and pardon my inexperience in this area, do you have a great shortage of general practitioners? Because there's been also a lot of discussion in the United States, for example, because of the shortage, about having that first line where many of these people first go to their general practitioners. And so, as you mentioned, training those with lesser, maybe, training, sometimes the general practitioners are in a better situation to try to at least help out where there's a shortage, if those individuals can't get to a psychiatrist. So that's one question I had. The other question that I had is, again, because we are talking, you talked about stigma, and you know, the stigma that you're talking about that we're seeing is, you know, there's still stigma here in the United States, but it's probably the stigma that was here maybe 30, 40 years ago in particular. You know, you're having that kind of stigma. But the question that I'd like to ask is, again, when we're talking about some of the cultures coming from Africa, from the Middle East, from Asia, is also the, what do I want to call it? The idea that, you know, this is witchcraft, this is whatever,
Yes.
as opposed to being a medical case. And I'm curious to know, you know, I know how we're trying to address it, but I'm curious to know how you're addressing that.
Anybody want to speak? Anybody want to speak to that?
Yes, I want to speak to the last one. Okay, but I'll say something about the board. The witchcraft issue is very high on the agenda, and especially in the mental health training. I think it's something that you people want to bring even closer to the table now than ever before. We have a psychiatrist who actually trained. I think she has an idea about these traditional healers, and she's lobbying us to have them included. However, one of the issues that we have with them, we are calling them complementary, and complementary is it's a very big group, including even the religious leaders and so on. But the religious leaders are saying, no, we cannot be bundled with those guys who do not have even, you know, whose things are not scientific at all and not known, and you know. But most of our clients in Uganda are doing double, they're calling it dualism. They will come to the health facility, but they'll also go the other side.
That's what I'm saying.
And they will go to, even within that complementary side, they would have more than one. They could go to the religious leader somewhere, then they'll go to a herbalist who will give the herbs, but then they'll also go to another category, the spirits, the ones who deal with the spirits, and you know,
the casting out.
Yeah, those ones. So it is beyond what we can legislate as such. But one thing that we've agreed as a country is we will work. We have put a definition for those people, and somehow we're excluding the spiritual. Not the religious leaders, but those are the guys who use those spirits and call on them and do that, the juju part of things. Somehow those ones are not being put under care for mental health services, according to us, because even the people who are sick actually, I mean, mention it and say, I went that side, they asked me for a goat, they asked me for this. It was a lot more expensive than it was to actually go for care, you know, to buy an extra month's dose of whatever medicine has or whatever medicine they're on. And of course, nothing comes out of that. So people are beginning to think through this process, and the peer providers are doing a lot of work in this direction, helping their colleagues who are just coming into the problem, telling them how they'll definitely tell them to go the other side, but helping them out and giving them the reality, that kind of thing. So yeah, that's how our situation is in Uganda in relation to the traditional healers.
I think I want to speak first to the issue of shortage. So I think I will reflect the mind of my colleagues. I think we are endangered species. Every day I struggle to stay back in my country. So Nigeria has about 200 practicing psychiatrists, but here in the US, I think there are more than 1,000 Nigerian psychiatrists. In the UK, there are over 500. So there is a big problem now, which is brain drain. So, and it's like a kind of, I won't say global conspiracy, but so the medical education, it costs so much, and the government is the one that pays for it. And I just have some level of patriotism that also I was trained in Nigeria. I was opportune to get an EU scholarship, go for global mental health. So am I needed in the UK? I think I'm needed more back in my country. But so I have that mind. So when I saw all the opportunity to stay back in the UK, I said, I've got to go back home. But I'm just very fortunate. You have a psychiatrist that has finished his residency, and for 2-3 years, he's got no job.
Yeah.
Though there is shortage, but the government is not employing. And so you see people moving down the Maslow hierarchy of need. They can't even sustain their basic need of life. And so the high income countries, they have an investment in them, but their waiting hands are there to take them. But will you blame them? You can't blame them. So there is deficiency, there is shortage, but the government is not creating space. There is poor incentive for work, even among the few mental health professionals that are available. 80 to 90% of them are skilled to the urban centers. And so people, if there were incentive for them to go to the primary health care, people will go there, but it's not there. And so they are living in droves. In fact, in my country now, there was a statistics last year that for all the doctors in Nigeria, at least 90% of them are considering leaving the country at one point in time. So even some of your senior colleagues will be telling you that, oh, what are you waiting here for? You better find your way. We are old cargoes, so find your way on time. So there is, the general practitioners are not even there. There is deficiency everywhere. And so people that barely, where the system doesn't tolerate you, doesn't even know whether you exist. So you see people trying to fend for themselves, going into private practice, and there is a disconnect between the private practice and the government practice. There is no connection. There is that mutual suspiciousness of what they're doing in private practice. So there's not really no kind of strengthening program for people that are in private practice. So it's just like a lone journey. And when the future is bleak for them, it's like there's something on the other side. And then to speak to the issue of the stigma, I think, like we said, stigma is everywhere, but we differentiate. Maybe more of institutional discrimination here, but you will also find out that the level of literacy has a lot to play in the kind of stigma that you see. So level of literacy back in Africa, you can't compare with this. And so the basic thing where we start from is the attribution. What do they see it as? So what was here like 200, 300 years ago in the UK, in the USA, that people believe in demons, that's where we still are. And what is fueling it is still these cultural beliefs. So if we will, what has been found to work, of course, contact, personal contact is part of it's been found to be one of the effective means to step down stigma, but also we won't start from where you want to start. It will be forced to increase mental health literacy. What do they know as mental health? They don't believe in this spectrum of health from wellness to the other hand. It's either black or white. They don't believe in the promotional aspect of mental health. So when they hear about mental health or psychiatry, it's disorder. There is no promotional level, no prevention. So we really have to go from the bottom-up approach to sensitize people correct their misconceptions, myths about mental illness, like, oh, it is witch, household enemy, no medication works. Once you get to see a psychiatrist, that's end of life for you. You never come off medication. Your life is, you're never going to have money again. You can't walk again and stuff like that. So it's stigma everywhere, but what is fueling it, what the explanatory model for it is somehow different.
I just want to give, I'm sorry, I just needed to give a story, a little one, just to tell you about the shortages that we actually have. There's a time when we have a standard, like for every level of facility, there's got to be this number of nurses, this number of clinical officers, doctors, you know, that kind of scenario. So given that the specialists, the little specialists that we have are first-time nurses, and then they go for further training. So some districts have found that, well, it's more cost-effective to have a nurse, a general nurse, than actually a psychiatric nurse. So we've had a situation where if the jobs go out, like there's an advert, they will never ask for a psychiatric nurse to be employed. So what these guys actually do, our colleagues, the psychiatric nurses, they just go in as general nurses, because that's what is being, you know, asked for even in the communities. So it's until they get in there that those that are patriotic, as it says, can start doing some work around mental health, you know. They'll say, you know, I'm a mental health specialist, so I can have a clinic. And, you know, we've had those, when we go for supervision, they tell us, they say, can't you lobby for me so that I can have a clinic? I could see my patients somehow. But, you know, the shortage is so big that no one will want to think about mental health. Mental health will come last, you know, it will come later. These other general infectious diseases will have to first be catered for before other conditions come in. So nurses have been employed as general nurses, but it's in there. But even where they're employed as psychiatric nurses, they're taken off the medical, they're taken off the psychiatric side and deployed into the general wards to care for the general, you know, patients. So there's that scenario. The shortage was cutting, but it's worse on our side.
You don't have public psychologists or counselors, it's psychiatrists and then general practitioners and nurses.
Exactly, that's very right. For our situation, yes. But you could find the psychologists in the regional referral up there. And even then, there could be just one. For instance, Butabika could be having, I think, about 3, but this is a national referral hospital. It would have like 2 or 3. And some of these are actually related with maybe a project. So somehow they're just coming to help with during the general care. But they are not, the psychologists are not part of the structure in clinical services. So this is where we actually think about the community health, where it will bring on board quite a number. And these guys are there, they've been trained. We have the clinical psychologists, we have the community psychologists, we have the counseling psychologists. There are quite a number of them actually. The universities are churning them out, but these are being taken on by NGOs. So those that are doing work, you know. So yeah, but I think it is high time we draw them on our side. They will definitely be very useful.
Well, in Nigeria, we have more of a multidisciplinary team, especially in the psychiatry hospital. So you have social worker, and mental health nurses, and clinical psychologists working together. In the teaching hospital, maybe there is less of that, but because of concentration of even the mega resources, is hospital-based model. So you find out that in the health budget of my country, it's less than 1% for mental health. And then out of that less than 1%, you have almost about 90% going into just the 7 psychiatry hospitals in the country. So they try to get all the resources available. But so I had that luxury. I had, at least in where I was trained, we had up to like 8 psychologists, but for like 365 bedded hospital. So, and then when I got to Abuja where I was, then that's another extreme. I had 6 clinical psychologists and there's no inpatient care actively. So what they do is counseling, some little stops. And I'm more of a public health person, community. So I said, oh wow. So when I became the HOD, I said, I need to get job for these people. We are underutilizing them. So, and when I put a proposal to the management that this is what my department want to do, I want to utilize these people. So I wrote a proposal. Everything we need is there. I said, I have the psychologist, I have the psychiatrist, medical social worker, I could pull them from somewhere. And that everything I need, I have the human resources. But now I had another very beautiful challenge. These are like a typical psychiatrist like me, people that are trained in clinical setting. So if you're now talking about community-based care, that's new to them. That's Greek. So but because I've gone for global mental health, I kind of have an idea of what I wanted to do. So I engaged the psychologist. I said, please, I want you to draw a plan for me of what are the basic psychological services you can deliver in primary healthcare level. Up to 3-4 months down the line, they are yet to get me that proposal because though they are technical, they are skilled, but they've never had that that kind of exposure. So when we were doing the image gap training, so I had to bring everybody in. I said, I know you are specialists, but none of us is specialists in delivering community mental health services. And if we are going to be supervising, then we need to know what works in community. And then just a quick one on the MH gap 10. It's good that that has been done in Uganda, and then Nigeria also have contextualized it, and they've actually piloted it in few places, but it's just about scaling up. But what has been fun to work is, it's not just about the training, it is about the ongoing interaction, supervision, and retraining. If not, you find out that the training that you've done, go back there 6 months, 1 year, it may not be sustainable. The decay constant can be very high, so that if, so there's need for retraining and continuous supervision of the people that we have trained.
I'd be curious, a chance and comments.
It's hard to put my thoughts around the complexity of what your countries are going through, because we look at our gaps and we see how we can provide, especially for our underserved immigrant population, but it's access to the resources in America, because we've got the insurance costs versus having the professional. So just thinking about how to get access. Can the families, can the mentally ill access those, or do they have to pay? I guess I'm loose on that association. So if someone's mentally ill, can they just be seen, or is it a step process? They have to go to the clinic first and then get referred to the center. I mean,
It goes back to the referral system. Maybe both can just take a quick minute, talk about your referral into the system, and then maybe the payment and the costing of it.
Okay. Regarding the referral system, we don't have just a bottom-up kind of referral system. The patient do not go to the primary healthcare setting and then come finally to the referral hospital. Either they are referred from spiritual, faith-based spiritual healers, or the patient can directly to the regional or referral hospital, to the mental hospital. And in Somaliland, it is completely public hospitals are free of charge, 100%, no insurance or Medicare, and also nothing is to be paid by the patient. Only maybe for routine or baseline just medical investigations prior to medications. They might pay a few dollars, but there is no payment, medication, admission, even inpatients do not pay for the service. No visiting or card payment. And in our hospital, we do have 50 beds inpatient, which are always occupied and very busy. And there is no payment from the patient or families. Service is free of charge. Despite the service is free of charge, maybe we do have difficulty in convincing family members this about the service that the hospital will provide, because family members want the patient to be in the hospital for a long period of time, or maybe for his entire life. Yeah. And we are just offering acute crisis management or stabilization unit. So we have difficulty in managing that. And I want to add on what you have said on the role of traditional healers is very important in our setting in Somali community. To tell you a scenario, once in 2018, where I was working in the hospital, a well-known spiritual healer come to that city, and then he was working for a massive community members with behavioral or mental disorders. And then families came to the hospital, and mom and dad, they are asking for discharge against medical advice to take to the chef. You see, to take to the spiritual healer. There are patients in the psychiatric hospital, mentally ill for 15 or about 20 years, non-psychotic patient, but the family still wants to be again take to. So there is you see, they look for everywhere. Still, they are not on the state of accepting modern mental health care. So that's why the service is 100% free of charge. Despite the service is free, we do have problems in accessing medication, consistency of medication, and also buying medication and covering all this cost is difficult. Despite the hospital do have many support partners, those abroad in UK and groups and associations in UK. And also we do have local voluntary community members organizations still handling and helping the hospital. We do have support luckily from the National Ministry of Health. So we all provide 100% service free of charge. Thank you.
But the picture is a bit different in Nigeria. So the health system in Nigeria, the major mode of payment is out of pocket. So it's high catastrophic spending. And about 65 to 80% of expenditure for health is out of pocket. And the health insurance scheme that came on board 1999, 2000, up to now, that's like 20 years. The coverage is still about 5%. And that is majorly for people that are working with government. And even that's just a little part of people working with government. Most of them working with the federal government. And then there's some private insurance scheme, but state has not bought into it. And there is a vague provision for mental health condition. But so largely people with mental health problem, their relative is out of pocket. And so you find people come to me, and then I do the assessment, need admission, and then they'll be begging me, oh, doctor, we have 65,000 and maybe it's 100,000 for 2 months admission. I said, mine is just to do my job as a psychiatrist. I can't, is the rule that they must pay for 2 months before they get them admitted. So you have people that need admission and have to be turned away. So it's like trying to do something and then you're trying to get people to trust you, to trust the system, to assess care. And then when they come, you push them away. So there are even times that the bed will be occupied and then people have private, people that work with government have their own private settings too. And so they will refer them there. So medication, there's the essential drug list, and then you find out a lot of paradox that happen in the system that there's no unified medication pricing system in the country. And so each hospital determines the price for the medication. And what I found out, which I'm still fighting hard for, is that I see patients and then there are times the medication are not available in the hospital. And so just across the road in community pharmacy, they get the medication there. And when they get it there, it's cheaper than what's in the hospital. So, and then, if you are talking about professional client fidelity for continued care, if you could get prescription cheaper outside, they just keep that. And so the next time, they just go for a refill, and then they never come back to you. By the time that they're coming, it's the management is so dynamic. You adjust medication, you adjust everything as per improvement, but it's just one size fits all. They just go, and it's when there's problem that they'll come back to you. There are times that you say, why did it take you this long to come? And then you want to feel bad. There are times that I was tempted to be talking back at the patient that you caused this relapse. The medication that you actually needed is less than $10 a month. But I started thinking that if they actually had the money, they would have come in the first instance. So, and what we find out is that so little can make so much difference. But even that little is not being made available in the system. It's so not to do.
So the Ugandan situation, I think I'm hearing, is between these two. I think we have both systems. Ideally, services in the public unit are supposed to be free of charge. However, lately they have decentralized a few services. So like, yes, seeing a health worker or the psychiatrist is free of charge, and the medicines will be free of charge for as long as they are not out of stock, for as long as they're in stock. But the numbers can be so overwhelming, given that the lower levels are not really working very well. They don't have the prescribers sometimes. So people tend to go to the highest level, and yet as much as the medicines could be available at the lower level facilities, prescribers are not so, they're not there most of the time. So the patients go up there to the regional referrals, and the medication there most of the time gets out of stock because of the numbers. The numbers are so overwhelming. And what our prescribers have been able to do is they're beginning to have a linkage with the lower levels. And since we've trained them on how to take care of patients with mental illness, the patient will go to the regional referral hospital, get a diagnosis, get their initial prescription, and then the refills will be done at the lower level. And in case there are any issues, then they will have to either call, the health worker at the lower level could be able to call the regional referral, maybe the doctor who prescribed, to just be sure that the medication and the dosages are okay. So that's a situation that has happened. But even then, even at the regional referral hospital, we have a private wing where, by the way, our mental health unit is one of the best facilities in the country. It's so beautiful. It's better than many other hospitals. So people have somehow the stigma has reduced a little bit, so someone could really easily go to Butarika. It's called Butarika Hospital. So, but once there, they can even choose to go to the private within Butarika, and of course, there it's out-of-pocket payments. But those who can afford, those who have their insurance with them, could also use the insurance system. I don't know about how they pay, but yeah. But one thing that I'm so certain about is that the mental health medicines are quite expensive. They're quite expensive. So for as long as they're not available in the facility, then people have to pay out of their pockets, and that becomes very expensive. However, sometimes these medicines can be at the lower levels. So there's that linkage. Like if someone fails to get the medicine in the regional referral, they can get it in the lower levels. But if they fail, they're not there, then they'll just definitely have to buy this medication from the private clinics.
Can I ask a question? Do you mind if I ask a question?
I just want to get a sense of time.
Okay.
It's about 6:20 now, right? 6:26. So, yeah. Okay, and I know I was hoping to get some feedback from the rest of you, so that we target to use maybe another 10 minutes to round up.
Okay. I hope this isn't a quick question, but it seems like a lot of the people on this side of the room are talking about mental health issues that are a result of trauma, post-traumatic stress disorder, conflict, and violence. But you're talking about mental health issues within your countries, which are not necessarily the result of those things, is what I'm understanding, especially in Somaliland, which you're saying is pretty peaceful. So how are we defining mental health issues? Because it seems like a really broad category, and it would seem like there'd be a number of diseases within that. You know, mental health isn't just sort of like there's good mental health and there's bad mental health.
Yeah.
I will let them give a quick minute each, and I will also add the larger context and get some feedback from what you're seeing, especially at the hospital.
Actually, recently now in Somaliland, there is no problem of peace and security. But you see, many war veterans. Yeah, in the past 30 years ago, there were massive war by the former Siad Barre, president of Somalia. Yeah, because there were national movement from the northwest side, so against the government. So many hundreds of thousands has lost their life because of that wars. So still the sequelae of or the trauma of that war is still there. And also there is problem of, in addition to the traumas, they used to keep, they are still using substance like khat, which
Substance
is
abuse.
trauma, and unemployment, and
So social ills.
Yeah.
Exactly.
Okay, I understand you.
and displacement that has contributed to the problem still.
Yeah. Similar to our situation, I think we've had pockets of civil unrest in quite a number of places, and of course that trauma is there. But again, it's substance use. There's a lot of substance use, especially among young people. But also the deprivation. There's a bit of poverty, and those other social issues that are coming in. So yes, we have lots of depression, especially among us women. We find there's some disproportionate distribution of depression in women. So, but basically, yeah, the drivers are those.
So in my country, in the last 9-10 years, there's been an upsurge of security use up in the north. you've heard of Boko Haram, HOP, and then so there's been quite a lot of, and where it's happening in HOP North, border states with other African countries like Cameroon, Sudan, Niger. So there is a whole lot of internally displaced persons in hundreds of thousands, and even the issue of refugees. So, and quite a lot of things there. And but the thing is that a lot of NGOs have come in. A lot of what they are doing are quite uncoordinated. But just like we say, what we've seen working, and then even apart from that, there's the issue of human trafficking, and then a lot of things that is happening in Hub East Africa, in Libya. So there's a lot of people being repatriated back to the country in their thousands, and a lot of them are having a lot of psychosocial issues. But the way to go about it, which I think they are doing pretty fine, is not using the medical model, but strengthening of the community system to have a more cohesive system so that integration and something more sustainable. Just about 2 months ago, the International Organization for Migration, which is a UN agency, contacted my center that maybe they'd like to have a partnership with us to develop something like a community-based livelihood program, which I think is more of the way to go. But so,
if I may refer you to a handout that I gave you on the framework for mental health recovery. This is part of the mental health action plan. It's also in your handbook, and page 12, or item number 7, where it says mental health linkages to human rights. So all of these pieces are essential components that are crucial in being able to set up prevention, intervention, and then tertiary care in a coordinated way. So I love the question you asked that, yeah, we have mental health in general, which is a medical condition, which we know is manageable and treatable. But then we have trauma that is caused by war and violence. Thankfully, the research that is now out there has made the connection that the discoveries made in trauma that is caused by war and mass violence. The same profile is also true in trauma that is caused by psychological abuse. I have patients here that I've served for 10, 20 years, who are born and raised here in our urban cities. The condition they describe, the symptoms, when they describe the symptoms, I could remove the name, but then look at my refugee clients from Iraq, or from the Congo, from Sudan, or from Burma, and their conditions are the same. Only that these have not been exposed to war, but they have urban violence and toxic violence. And so the end result is the same, that you have the same challenge.
Just a comment on that, I think I also work in a psychiatric hospital, and coming even from a country where we don't see a lot of war and violence and things, a lot of the same issues in your naming, obviously trauma, substance abuse, even a little bit with human trafficking, but a lot of those same issues even here in our country are coming into the mental health treatment sector as well.
And so this is where I think, again, this is a huge elephant, if I could use that more, with a huge problem, and all of us can only touch a little bit of what it is. So, Nathaniel, I would be curious to see where you are with any
Well,
comment.
I was really kind of concerned because when I'm seeing it from the high school perspective, and our biggest problem right now is it's probably going to be wealth versus inability to get treatment itself in terms of, again, and I don't want to call it poverty. I just call it, I think our society right now has a different value for seeing where, again, mental health is, again, attached to or moved to it. We're beginning to become more, I think, effective as communities, and I like really the community model that I'm hearing, to make people more sensitive to Because if you walk down, even in the United States, you're visibly seeing people with mental health disorders on the street in different places, and we just go on about our business like it doesn't affect us, and we're waiting statistically to hear that they've done something. I had a young man who I was working with. We knew he had every incident of mental health. The only treatment he had, he's now in jail because he really got violent. He killed someone, and he was in the criminal justice system under some types of mental health. They couldn't get him medication because of income, a lot of different things. It's just we don't have that, what I would call sensitivity to the concerns of the community. And that becomes more of my concern. How do we get the people who are, what do you say, treatable, touchable, but you can't get to the layers of whatever it takes to get them basically what they need? We're becoming very receptive, I think, now in school communities. Mindfulness is being placed in. You are having nurses, other people inside of institutions who are helping, but that's just a very small. It's on the top of just the needle in the haystack in terms of being able to do what you need to do. And so I'm very concerned about those models that you have brought with sensitizing communities that this is a concern for the community. I think that's first. And then secondly, how do we empower more people on the very local basis to be able to work with people who are salvageable in terms of what we can do. So you open up a wealth of knowledge in terms of, with that larger population of people, just first of all understand this is a real issue. And in here, Irish in the United States is housing them away at an institution, thinking that that's going to be the way to solve the problem, but we need to be dealing with the community in terms of understanding that.
But we don't even institutionalize people nearly as much. I mean, the 70s and to the 80s, that really went away. We have a huge mental health complex not far from here. It's empty because we changed laws. And so we have other people now. So those people are now in the prison system, on the street, living in the community.
Neglected. There's something that I observed. I was watching television when I just came in, and there was this teen program. I don't know whether some of you listeners have watched it. And there was this child, and it's a child interviewing another child. So this child was talking about what they had done. So he said he got excited. He started the program because he had gone to some place that I think for a picnic somewhere, that gone out somewhere, and there was this bird that had either lost its mother or something like that. It was a bird that was so lonely, and somehow everyone seemed to want to care for it, and were taking pictures of what they had done. They were bringing food, they were keeping it warm, and then this young boy said, but when I went back home, I found this destitute. He did not have anything to eat. He was begging, and people did not seem to care about this man, this human being. So he said, no, but we're caring for the other bird. Everyone was so excited about, taking care, and we're not doing anything here. So he said, that little boy said that he had some money with him. He said, and this man was just looking for food. So he just got some food for him, and he couldn't do much, but it really excited him. He said he looked for blankets because he only needed, like it was very cold and he needed to be warm and he needed food. And that's how he started. So he had mobilized his colleagues in school. Anyway, he had a program. So he was talking about that program. But I also felt touched. And the young people, I think we need to get, those of you who are in schools, I think that's so wonderful. If these young people start off with that spirit of wanting to help, knowing what it is, and I think the generation may get much better. So I think also as back home, we need to get into the schools and involve the young people.
And that's also where you start and even here in the United States, the idea of whether it's mental illness or physical disabilities or mental disabilities, the idea of destigmatizing, as it started many years ago, but it began in the schools. And so then than children now. They may be sitting in a classroom with students with many different, conditions, but they consider them their colleagues and their classmates. So that's changed quite a bit. I remember when I grew up going to school, kids that had any issues were always kind of like in their own classroom. It was almost like the scary classroom. You didn't know what was in it, but now they're all kind of, absolutely.
I think it's helpful to embed mental health providers in so many of our institutions, in the schools. It'd be great to have them in all of our resettlement agencies for refugees. I know in some parts of the country they do. And then, so I work in a primary health clinic, so it's mostly nurse practitioners, and then there's a few mental health providers. And I think that helps to reduce stigma when they can just send them down the hall. So our providers can prescribe the medication, and they say, that's not enough, you really need treatment too, and then they can send them. And I just want to say one other thing about refugee and immigrants, because our clinic serves 90% of our clients are refugees and immigrants, because we serve people that are uninsured and we serve refugees who do have insurance. And so it's complicated because there's also a very strong anti-immigration feeling. And so most of the immigrants that come to our clinic would love to have refugee status because they're undocumented, even though many of them have come as a result of forced migration, as a result of fear of violence or devastating poverty. They don't have the safeguards that we give refugees. And there are, I think it's been part of the
insurance.
No insurance, and they're missing a lot of the services. They're 80 years old and they've been paying Social Security for decades, but they can't collect on it. They're going to have to work for the rest of their lives. So, so it's complicated, the whole refugee versus immigrant issues here, particularly now in this climate.
Oh gosh, so much being said. I think some of what I'm hearing, I hope we have a chance to continue the conversation tomorrow when we're at UWM, because when I think of the challenges you're facing and the challenges we're facing here in Milwaukee with I don't like calling it mental illness, but there's treatable mental illness, but behavioral health and wellness. I see the problem not getting smaller because of climate change, economic stress, all these different challenges, that the only way we're going to make the situation better is having this whole of community approach where it's not just a psychiatrist's job. It's like you were talking about. It's all of this. We're going to get the empathy training, the mindfulness, all of this together, just the way we've done with children with special needs, like you were talking about. There's still the issues that are to be addressed, but everyone kind of embraces it as our responsibility. And that's where I'm looking forward to continue this conversation. How do we make that community aware that we all have a responsibility and a role?
I wanted them to speak more on the school-based program. What's the component and what's it really all about? What model is it? Is it identification of active case, or is the whole spectrum of promotion, prevention, and then tertiary?
Sure. Well, what we've come to realize, please come in. With services, students are an access point for mental health. And we know that there's a lot of taboo with mental illness still, so we've taken to calling things mental fitness. And so we have a mental fitness program in our schools. So our social workers, counselors, psychiatrists can identify which students are having mental fitness issues that aren't academic, that aren't they're naughty on the bus, right? These are things that they need access to mental health services. Due to regulations, the school district would need to call the families and say, would you like to talk to our provider that we have as a partner? Once we get a release of information, then we can send our information to providers. So Dr. Sebastian would then get that. Their clinicians would then take over and do the intake and figure out what services are needed. Is it domestic violence? Is it refugee status? Is it mental health? and then our providers would be able to come into the schools and utilize our space, but use it as they need to do it. So it's a true partnership. We provide the access point, but maybe it's family therapy that's needed, maybe it's domestic violence services, and maybe it's access to a psychiatrist, and then his clinic would arrange those things, because the schools, we don't have a charter to provide any of those services, but we can certainly help. And so our staff have been much more adept at identifying the low-hanging fruit for which students and families will buy into the program, because if they say no, that's time and effort that's gone by the wayside versus families that can use that support. Not to say a really critically ill can't use that, but oftentimes they're not the ones who are reaching out. And so what we've seen is that students that access these mental fitness programs have better attendance, the families report lower stigma on our evidence scales, they report feeling better, and they feel better based on how much they see the clinician. So if they see the clinician a little bit, their scores go up. If they see them for 3 months, we know that it's going to make an exponential difference. And so we've been doing this for 10 years now, and can show that it's really impacting the trajectory of our students that graduate at higher levels, that the families then start to buy in that mental health isn't a bad thing. And so you start at the schools, build some trust, and then get the families to talk about what the real issues are. That's answering
It's so
your question.
wonderful, yeah.
Let's take it to another loop, just another level. We've really been fortunate, and it really has a lot to do maybe against the schools dreaming as a smaller community. But right now, some high schools have branded with mental health providers. And basically, within that school context, through their school counseling department, they can refer them out for family counseling, for student counseling in terms of individual. And they can go for a number of sessions free of charge via the school. So that's began to help also, especially on some of your high school components where people just don't have access at all to insurance or have others. It's through the schools providing access. So they're actually getting to go to other clinicians via that school route that's there.
I'm so fortunate to have one of our refugee settlement agency rep and everything. I'm so glad to have you here. I just want to say a word or two.
Oh my goodness, I have so much to say. I'm so sorry I wasn't here from the beginning because I was at a meeting in central Wisconsin today talking about comprehensive community services for people living in the community who needed mental health supports to continue to do well in the community with their family or where they choose to live. And before I came to work for refugee resettlement, I worked for many years working with people just out of a psych unit coming back into the community. And I did that for a long time. One of the things I was hearing today was this sense from county people and my own agency that we would like to get into refugee community services because you have the language capacity. And I'm thinking it's so much more than that. It's relationship. It's understanding. You want the person going in to be very mindful of their own biases about mental health. You want them to believe in the treatment plan and the goals of the client and how in a very supportive way. It's not just language. So I've had my work ahead of me for that. And about the spirits, I think that's so interesting because I was raised Catholic. And I was always told, if you want this, pray to this person. If you want this, you pray to that person. There's so many similarities between traditional beliefs and then institutionalized religion. So that's another bridge that I often make with my team. You know, it's not weird. It's just very similar to what else is going on. Kind of normalizes everything. And Debbie, you mentioned about having mental health practitioners. I wish we could have them in our office, but we just can't do everything. But I think there's a lot of merit in having refugees. We've referred many people to Dr. Sebastian, and they have complete privacy by coming here. And it's separate from the resettlement agency. No one even knows they're going. And we don't even know they're going sometimes. You really do some wonderful work. We've seen some really nice recovery and people being very stable. But I think that there's a certain, when they go to a clinic like Walker's Point, they see other people who are not refugees. It kind of normalizes the whole thing. And I think that's important.
Thank you so much.
The religious leader hasn't said nothing, so anyway, but I would, I don't know how he does his preaching. Is it more of counseling or emphasizing the Bible and to people?
Okay, let's see. I do again, I'll introduce myself. Basically, my primary job right now, I work at a hospital chaplain. Okay, and I have interaction with the patients on the daily basis. So when I'm visiting with the patients, of course, with different kind of conditions. So in my case, okay, I come in to offer spiritual and emotional support. So right now, with my experience as a working as a clinician, as I work with the patients who are struggling with a lot of issues, mental or with substance abuse, so I come in, I'm able to, I listen, I offer spiritual and emotional support, but also I encourage them to go to the next level. Working together with the interdisciplinary kind of team. Okay, so okay, this is what I'm hearing. Okay, have you been able to even raise this to your doctor? Okay, and what do you think? What's the next step here? So it is very comprehensive. It's very comprehensive. So.
Okay, so you're part of a team that does. Okay.
Yeah.
Yeah.
Hospital chaplaincy is very common here. Hospital chaplaincy. And a lot of the chaplains work with all different faiths, so they're not even specific for a certain faith. They work, they have some general guidelines for all of the people in general.
In the, as she mentioned, the psychiatric hospital that I work at, our chaplain, he again works with patients of all faiths. We have Native American patients who practice their more traditional religion. We have just a general Christian service every week. He does Bible study groups. So again, it's a general chaplain who addresses all sorts of different faith traditions.
Okay, that's wonderful. It's not part of our system back home, but the HIV prevention care model has that on their package. Yeah, so
What's it called? Yeah.
the HIV care package, the HIV treatment package, usually has that on their as part of their system, but not the mainstream government services. Although we also find that they could also be there in the NGO, I don't want to call them NGOs, but okay, those institutions that are set up with a religious background behind them, then they would have the chaplains. Yeah, the faith-based organizations would have some of that, but not in general care on our side.